Hi there, my name is Dr. Douglas Schottenstein. I am a practicing interventional pain management physician in New York City. And one of the most common conditions that I see in my practice is back pain. Back pain is very complicated, frequently multifactorial, and it affects millions of people worldwide. It's also probably the second most common medical condition in the United States, probably secondary only to headache. Frequently, because of how complicated it is, a multimodal approach, including medication and intervention, is often employed to achieve lasting remission. While medications such as anti-inflammatories and opioids can give global, meaningful benefit, interventions are less global, more targeted, and more focused on specific pain generators. The prevalence of lumbar or cervical facet joint disease associated with back pain is unknown. But the facet joint is a true synovium-lined joint, allowing the spine to flex, extend, and rotate. And many conditions exist that produce facet disease, the major cause of which is osteoarthritis, which is the degenerative condition that results in reduction or loss of the facet joint cartilage. This can cause the sensory nerve endings innervating the facets and the surrounding tissues to become irritated or inflamed, and because of that inflammatory process, a patient may, in fact, feel pain. Imaging and physical exam are notoriously unreliable for the diagnosis of facet pain, but once the diagnosis is even entertained, a diagnostic low-volume intra-articular facet joint injection or a block of the nerves that innervate the joints, called medial branch blocks, can be performed. These intra-articular and/or medial branch blocks, when successful, limit or even completely resolve facet-mediated back pain, but their durability may be limited. So more prolonged destruction of facet-mediated pain is often sought. Radiofrequency denervation has been shown to be effective in the treatment of facet pain, especially in patients who have an excellent response to these aforementioned facet injections or medial branch blocks. The radiofrequency technique is well suited to facet denervation, mostly because the lesion size, the temperature, it can all be well controlled. The lesioning does not impair the basic architecture of the nerve. The axon is largely intact post-procedure. But the denervation is long-lasting, and nerve regeneration, while typical, takes a long time, typically 1 to 3 years. So with proper technique, the patient may have a significant pain relief for 1 to 3 years, and this, again, may be reproducible. The procedure itself is not complicated. It's rather basic, rather quick. In the lumbar and thoracic spine, for example, the medial branch of the dorsal ramus courses over the base of the transverse process at the junction of the superior articulating process. And each facet joint has dual nerve supply. For example, the L4-5 facet joint has nerve connections with the medial branch nerves that courses over the base of the transverse process of L4 and L5. And the names of these nerves would be L3 and L4 medial branch nerves. So during denervation, the patient is placed prone on the fluoroscopy table, as he or she would be for any intervention, spinal intervention, and the low back is prepared in a typical sterile fashion. Once the medial branches are approached using the traditional needle manipulation techniques, sensory motor testing is performed, and once proper position is assured, a radiofrequency generator delivers probably 70 to 80 seconds of lesioning at typically 70 to 80 degrees Celsius. And post-procedure, patients typically feel slow onset of benefit, and the maximum effect usually occurs probably 1 to 4 weeks post-procedure. As I mentioned previously, the benefit is typically durable. The benefit typically is 1 to 3 years in duration. And although patients will not be cured of their pain, the dramatic response is, again, reproducible. So within the model of multimodal management of back pain, radiofrequency ablation is just another advanced tool useful in hopefully making a dramatic impact. Thank you very much.
My name is Dr. Andrea Trescott, and I'm a professor of anesthesia and pain medicine at the University of Washington in Seattle. And I was going to spend a couple of minutes today talking about my approach to low back pain. There are multiple causes of low back pain. In fact, we estimate as much as 80% of the time we can't tell where the pain's coming from. At least we can't by an MRI. But I do believe that as interventional pain physicians, we have a better opportunity than most to be able to identify perhaps where the pain is coming from. And if we can identify where the pain's coming from, then we have a chance to actually try and treat it. So when I'm looking at somebody with low back pain, obviously the first thing I do is take a history. And there are things in the history that may give me a clue about where the problem may be coming from. Somebody, for instance, who describes walking along and then suddenly having his leg give way is something that Tom Dorman described as a slipped clutch and is usually associated with a sacroiliac problem, as is the patient who describes pain going from one side to the other, especially if it's below the belt. If somebody's describing pain that started in the upper back and now moving down the leg, that might actually be a problem with a transitional vertebrae between the thorax and the lumbosacral region. Then, after I've done the history, I look at the physical exam. And it's a very directed physical exam. The first thing I do is have the patient point to where it's hurting. And you'd be surprised how many times the patient actually points to where I end up finding the pain is coming from. So I look at it. If I took my hands and put them on top of the iliac crest, thumbs in the midline in the back, then I describe everything else the patient points to in relation to that. Is it above that in the midline? Well, then it's liable to be either an interspinous ligament problem or facets. Is it at the posterior superior iliac spine, or PSIS? That's liable to be a sacroiliac problem. Is it at the top of the hips? Maybe a cluneal nerve. If it's in the butt itself, is it at the superior gluteal nerve or the piriformis? And then I look for some patterns. If somebody has a sacroiliac problem, since the piriformis muscle is the only muscle that holds the sacroiliac joint together, then I'm going to look for a piriformis as well. And if I have a chronic piriformis problem, I'd expect to have a distal piriformis problem as well. So those all seem to go together. I then think about the back in terms of three pieces. I think of the posterior elements, which would be the interspinous ligament, the facets, and the sacroiliac joint. Then I think of the middle column, which would be the epidural space and the nerve roots. And then I think about the discs. So when I'm evaluating the patient, if I can feel something, then it has to be in the posterior elements, because I can't feel the epidural space, and I can't feel a nerve root, and I can't feel a disc. I usually start there because those are the safest and the most straightforward sorts of areas to try and inject. The approach I use is a modification of the American Society of Interventional Pain Physicians' algorithm for low back pain. If I think it's sacroiliac, I always start there. It's the most straightforward, and it can cause a great deal of different issues. On the other hand, if the sacroiliac doesn't give relief, then it may be a problem with the facets, especially L5S1, which is very closely related to the sacroiliac. If the facets aren't the problem and the sacroiliac isn't a problem, then I look at epidurals. Now, when you look at the evidence base for epidurals, you'll see many groups. The American College of Occupational and Environmental Medicine, by ACOM, or the neurologists have recently done guidelines and have suggested that epidural steroids aren't effective. ASIP, the American Society of Interventional Pain Physicians, also did a set of guidelines, but what they did is divide those into interlaminar epidurals, caudal epidurals, and transforaminals. And what we've been able to show is that though the interlaminars are not necessarily that effective, the caudal and the transforaminals are very effective. So in someone who has a low back pain, something that's at the level of the waist or below, then I usually look at a caudal epidural, because that allows me to be able to do a good epidurogram, see where the medicine's going, see where it isn't going, and look for epidural adhesions that may be causing pain. If I see that medicine isn't going out a nerve root, I may do a transforaminal at that level, especially if the MRI suggests that there's foraminal stenosis or that there might be a bulging disc at that level. Or I may try and do a catheter technique to take a catheter up through the tailbone and out the nerve root involved and see if I can get medicine out that way. Or I may actually get much more involved and look at spinal endoscopy, where I can actually take a camera up inside the spinal column and look at the nerve roots and be able to tell by looking at them and whether there's a problem, and actually potentially under direct vision lyse the adhesions around the nerve root. If I've gotten good flow of contrast out the nerve roots and they get temporary relief, but the pain comes back, or if I've got somebody who's got adhesions who wouldn't be expected to have adhesions, somebody who had a virgin back, for instance, I may look then at the disc, because not only did the disc cause pain by the direct compression of the nerve, but it turns out that the disc material is very irritating. And if it leaks out onto the disc, onto the nerve root, which, by the way, may not show up on an MRI, then that can potentially cause pain and inflammation. And if the disc leaked and then healed, you still have those adhesions that will prevent the nerve root from moving smoothly. So I may look at a discogram to see if there is a discogenic cause for the low back pain. Now, each of these have their own risks. Each of these have their own evidence. And we've been under, pain management in general, has been under a great deal of criticism recently because of the lack of good evidence. And I think that actually has to do with how the studies are done. Because if you take place a needle on a structure and then inject just local anesthetic or local anesthetic and steroid, those are not comparable procedures. That is not a control and an active. They are both active agents. One is just potentially more active than the other. There isn't, because what you need to realize is that when you stick a needle in, you change the structures that are in that area. You stimulate a response. You stimulate blood flow. You get a conformational change of the fibroblasts. And so it is not a control to do that. To get a true control, you either need to do a sham study or you need to use the patient as their own control. So, for instance, if you've got somebody with bilateral pain, you treat one side one way and one side another. We've looked at dual local anesthetic injections, where you inject one time with a short-acting local anesthetic like lidocaine and another time with a longer-acting local anesthetic like bupivacaine. And we thought if the short-acting local anesthetic only lasts for a short period of time and the longer-acting local anesthetic lasted for a longer period of time and the patient didn't know which was which, that would tell us that it was not a placebo response. Well, the problem is that not all patients respond equally to local anesthetics. And we've now recognized with skin testing of local anesthetics that as much as a third of the patients who have a history of difficulty getting numb may not get numb to lidocaine or marcaine or actually even mipivacaine. So for those dual local anesthetics to be effective, you first have to be able to treat and identify what local anesthetic works the best. And all of us have seen people who've gone to the dentist, one who has to get injected multiple times during the dental treatment, and another who's numb for 6 hours after a short-acting local anesthetic. So I think until we know more about local anesthetics, we can't rely exclusively on the dual local anesthetic evaluation. I think instead what we need to be doing is recognizing that it's sometimes difficult to do a true placebo-controlled trial, just like in cancer pain. Nobody gets a placebo. What they get is they get an active or new treatment compared to a standard or old treatment. Now, in interventional pain, we've been comparing the injections with and without steroids or with and without Serapin or a variety of things such as that. But what we haven't done is actually compared them to, haven't done enough, to compare them to what would be done instead of doing the injections. So physical therapy and rehabilitation or surgery are the things that we should be comparing these procedures to, not to each other. My thought on the process and my 2 cents worth. So I hope this approach has been useful to you. In the study information that is included in this is a copy of a sketch looking at some of the structures that I've talked about, the cluneal nerve, the superior gluteal nerve, the sacroiliac. And you'll also see a copy of the ACEP algorithm for evaluation of low back pain. Now, we've got wonderful treatments for low back pain, and nearly every day we come up with an improvement in how we treat and evaluate low back pain. Unfortunately, there are a group of patients that we don't have much to offer in terms of treating the cause. Many of those are patients who've already had back surgery, though some will be patients who've not had any surgery at all. Unfortunately, once they've had surgery, the whole structure has been changed, very much like cutting a few cables on a suspension bridge changed the stresses on the rest of the cable. So for those patients in whom we don't have much to offer, we look at trying to see if we can exchange pain for tingling. Now, that's what we do with a TENS unit, a transcutaneous electrical nerve stimulation, which are pads that are on the skin that use an electrical signal to exchange pain for a buzzing sensation. Nerves can only carry one signal at a time, and if they're busy carrying a non-painful signal, then the painful signal can't get through. That's actually the same reason that when you bang your shin, you rub it, because that rubbing blocks the pain signals. If you have a patient who has primarily extremity pain, an arm or a leg, this was the original type of patient that did well with spinal cord stimulation. And we could use an electrode that had, a lead that had 4 electrodes on it, or 2 leads that had 4 electrodes on them, and be able to reliably get tingling in the extremity. But we had trouble getting back stimulation. And unfortunately, most of our patients, that's the primary thing they complain about, is the back and not the leg. So what we've started looking at is then leads that had 8 electrodes, and then 2 leads of 8 electrodes. And recently we've been using 1 8-electrode lead and 2 4-electrode leads, what's being called a tripole, to try and get stimulation deeper into the spinal cord itself, which is where those back fibers lie. As we started doing that, we started using that same technique in the cervical region to treat arm pain and now neck pain. We also then recognized that though you could take the stimulator up the spinal cord, which is now called antegrade, it's possible also to thread the catheter down the spinal cord and out an individual nerve root, so that you could stimulate just L5 or just S1. And in fact, slide electrodes all the way down into the pelvic area to stimulate the sacral nerve roots. That we also were using then, trying to do that spinal cord stimulation for visceral pain. So we've used it for angina, we've used it for abdominal pain, where we think it's a visceral problem, pelvic pain, stimulating the spinal cord directly laterally, usually over at the lower thoracic regions, LT10, 11, 12. And then we've also used the spinal cord stimulation to improve blood flow to the extremities. And in fact, that's probably the most common reason that it's used in Europe, is limb salvage for people with peripheral vascular disease. And in that same way, because we think the stimulators block the sympathetics, we've used spinal cord stimulation for chronic regional pain syndrome, or what used to be called RSD, because it can potentially improve blood flow and block pain. We've then looked at stimulating directly through the sacral nerve roots so that you can stimulate the pelvis. And we've actually taken electrodes back up through the sacral hiatus to stimulate the sacral nerve roots. And now we're also looking at stimulating individual nerves. So we've put spinal cord stimulators across the back of the head in the occipital region. We've looked at them in the brachial plexus, on the sciatic nerve, across the pain area of an inguinal hernia, or even on an individual nerve like a perineal nerve. So the world of spinal cord stimulation, or better living through electropharmacology, has been improving and improving as we start using electricity to provide pain relief.